It's called Integrating Behavioral Health into Primary Care, and it's a 5-year project funded by the Patient-Centered Outcomes Research Institute. It's going to help us investigate how to improve the outcomes for patients with behavioral health problems. It's a broad spectrum of issues, including depression, anxiety, insomnia, stress, problems taking your medicine, getting enough exercise, eating right, all the things that a patient's behavior influences that also interact with their medical problems like diabetes, hypertension, heart disease, asthma, those sorts of things. So it turns out that there's good ways to manage these behavioral problems, mostly around counseling, cognitive behavioral therapy, motivational interviewing, good counseling skills, but it turns out they're hard to get. Most of these patients will present to primary care rather than directly to a behavioral health specialist. And in primary care, we don't usually have the resources, the skills, the training and background to take care of these folks. Traditionally, we'd write a referral to someone in the community, a counselor. There's a big voltage drop-off. Of all the people who need therapy, we write a referral. Less than half of them even get an appointment made, and less than half of those will get to the first appointment. So people have tried what's called co-location, where they put the services right next to primary care, right down the hall in the same building, sometimes in the same suite. And that helps some, but there's still a lot of barriers. In my own practice as a primary care internist, I see an awful lot of patients with these behavioral health problems. And it's been quite difficult to get them the level of service they need. Referrals to the community don't always work as well as we like. And even when we have services right near our own practice, there's still a lot of barriers to care. So we've developed a model of integration of behavioral health right into primary care. And that means not just co-locating, but really redesigning the primary care practice to completely include the behavioral health care. So we've got shared space, we've got shared support staff, we've got the primary care docs, the internists and family docs, interacting with the behavioral health specialists on a daily basis. They talk to each other, they share the notes. They've got systems to identify patients who need treatment and systems to automatically get their appointments made. So these are good systems solutions to delivering a level of care that there's good evidence will work. What can we do to make it happen? Well, we've got to redesign the primary care practice. We've got to train the primary care docs. The behavioral health clinicians need to be trained in the best evidence-based methods, and we've got to train the support staff to do it. We'll be doing this over several years, and it'll be a randomized study where some of the practices get that right away and some of them don't, and we'll compare how the patients turn out in the two arms over time. It'll take about 5 years. There'll be at least 30 practices and probably close to 2,000 patients involved. They're going to be all over the country. We've got people in Kentucky, Georgia, Arizona, Anchorage, Alaska. Practices all over have volunteered. We've got a long history of top-notch behavioral care right in Vermont. We've got already have some integrated practices here associated with the University of Vermont Medical Center. The leadership of the project includes faculty from the University of Vermont, including medicine, family medicine, engineering, mathematics, and statistics, as well as patients who are on the project as co-investigators. They're going to be working not just as consultants and volunteers, but actually on the payroll to assist us in every design aspect of this study so that it really reflects what's important to patients and what their needs are. It's a relatively new model of doing research, and we're very excited to be using it.